there's been a few trials looking at monotherapies with metastatic prostate cancer, and you're correct, there were 0-17 patients treated with nivolumab or anti-PD-1 that did not have any responses. And we believe the reason for that is because there's very little T cells in the primary or in the metastatic prostate tissue. And these T cells can help upregulate PD-L1 and PD-1 in the microenvironment. And because of the few T cells, there's few PD-1 and PD-L1, and therefore you're not getting the responses that you would have seen in other diseases such as lung cancer and melanoma. Now, there's some activity with anti-CTLA-4 ipilimumab, and it led to 2 phase 3 trials being run in prostate cancer with ipilimumab. And in those cases, both trials showed that there was no overall survival benefit when compared to placebo. So our group then looked at our patients that had been treated with ipilimumab to better understand what was going on. And what we saw was that ipilimumab drove the T cells into the tumor microenvironment, which was exciting. The T cells were activated, they had a memory phenotype, they had a license to kill, they had cytolytic activity, but they weren't killing the T cells. And then what we found out was that the microenvironment had upregulated immune checkpoints such as PD-1, PD-L1, and VISTA, and that prevented the T cells from killing. So we went back to our preclinical models and looked in our mice, and we treated the mice with both anti-CTLA-4 and anti-PD-1, and we saw remarkable responses. That led to the design of this current trial, where we gave both anti-CTLA-4 and anti-PD-1 in our patients. So we found that in these heavily pre-treated patients that the combination could actually lead to some dramatic responses that are durable, and it's a very exciting finding. We have 2 patients in our own institution that have been over a year and a half, and their PSAs are 0, and with no evidence of disease. So one of the things is that not all patients are benefiting from this approach, and so we need to find biomarkers that will help us improve our patient selection. Right now, one of the most promising biomarkers is looking at the tumor mutational burden, and the median for this cohort of patients was 74.5 total somatic mutations. And the patients that had greater than 74.5 mutations were more likely to respond to the immune checkpoint therapy. So we need to really evaluate this in a larger cohort of patients to see if this is really predictive of who's going to respond. So that's a great question. We don't know yet because we are actively evaluating the changes in the microenvironment as a result of these treatments. But we assume that if you look at the mouse studies, that the T cells are coming in and these T cells are activated, and so it's changing this cold tumor microenvironment into a hot tumor microenvironment.